So today we'll be discussing about a long answer question that is very commonly asked, and that is autoimmune hepatitis. Now, it's very important topic, as well as this is very commonly seen in clinical practice. Now, what is autoimmune hepatitis? It is a chronic disorder where there is continuous hepatocellular inflammation, hepatocellular damage that ultimately leads to necrosis and fibrosis, and it actually ultimately leads to chronic liver disease or CLD. So if it is not treated, then it definitely leads to cirrhosis and hepatocellular failure or liver failure. Now there are total three types of this autoimmune hepatitis, that is type 1, type 2 and type 3. Now why it is important is basically because in type 1 is very commonly seen in young female patients, and the patient may have lupoid or lupus like features. So the features will come to know again after some time. And these patients very commonly they have ANA positive, that is anti-nuclear antibody positive. So if we find a patient, or if we want to label a patient as autoimmune hepatitis, if the patient is young female patient presenting with lupus-like features, and if ANA is positive, that is very highly likely to be type 1 autoimmune hepatitis. Type 2 autoimmune hepatitis is seen in children where ANA is very commonly negative. So if ANA is negative, if the patient is child, then it is going to be autoimmune hepatitis. But in these patients, we can find the anti-LKM antibody positive. And in type 3, this is also very common in female patients where they are negative for ANA as well as anti-LKM antibody, but they do have positive antibodies to soluble liver antigen or liver pancreas antigen. So we can send these antibodies to soluble liver antigen or liver pancreas antigen. Now, what are the clinical features? Is very common. It's very important to know that the patient may have insidious onset or abrupt onset. So, patient may have some creeping clinical features that are there since months, weeks together, but they finally come to know this diagnosis after getting investigated. This is very common in females, as we have seen. Type 1 is seen in females, type 3 is also seen in females. So this is much more common in female patients compared to male patients. Now, these patients very commonly have recurrent jaundice. Now, what we are talking about is hepatitis. So, we are talking about liver. So, these patients tend to have repeated liver symptoms, which obviously are jaundice, recurrent jaundice, and recurrent acute hepatitis. That can be seen with a deranged LFT, that is a raised ALT, or raised AST, that is SGOT, SGPT, and SGOT. So the patient may have nausea. Now, whenever we see hepatitis, whenever we are talking about liver, as liver is the main organ for digestion, that is the reason why very commonly the most common clinical features are reduced appetite, nausea, vomiting, and as this is an autoimmune thing, so there is an inflammatory cascade, inflammation going on, causing malaise, abdominal pain, non-specific joint pain, and some other lupoid-like features which can be there is colitis, pericarditis, dry eyes, dry mouth, which we call it as Sicca syndrome. The patient may have erythema nodosum and rash. So these are very common features that we can get. Many of the time, the patient may get diagnosed only with cirrhosis. So those patients with autoimmune hepatitis, which are not investigated, which are not treated, they directly present with cirrhosis. So whenever the patient present with cirrhosis, cirrhosis is CLD, that is chronic liver disease. So the most common presenting feature of cirrhosis or CLD is ascites. So ascites is accumulation of free fluid into the peritoneal cavity. And the patients, whenever the patients have ascites, whenever we say that the patient has CLD, we very commonly see hypoalbuminemia. So whenever there is low albumin level, there is a reduced oncotic pressure of the blood. So automatically there will be edema. So the pedal edema is feature of hypoalbuminemia. So presence of ascites, edema, these are very common features of cirrhosis in general. So if the patient has ascites, CLE, the chances of having encephalopathy is very, very high because liver is the organ which removes all the toxin things in the blood like ammonia, epurates, sulfates, indoles. So these things are not eliminated by the liver because it is damaged because of the autoimmune hepatitis. The patient may have encephalopathy because of the cirrhosis, because in the cirrhosis liver becomes completely shrunken. That is the reason why there is portal hypertension, and as the portal hypertension is there, there is splenic vein hypertension, so automatically we get this splenomegaly. So very commonly, as these patients have very reduced appetite, nausea, vomiting since months, years together, and because of the splenomegaly, hypersplenism, these patients very commonly have anemia, leukopenia, and thrombocytopenia as well. Because of the CLD, because of the leukopenia, because of the reduced appetite, because of the poor nutrition, these patients have increased risk of infections. So these patients may directly present as maybe a urine tract infection or respiratory tract infection or pneumonia or brain abscess or any infection. So sepsis is very common, and when there is hepatocellular failure, these patients very commonly have coagulopathy because liver is the organ which synthesize all the clotting factors. Almost all the clotting factors are synthesized in the liver. So for the production of prothrombin, it is very, very important. So clotting system, one of the most important thing is liver, and in liver disease, in autoimmune hepatitis, as liver there is continuous inflammation and damage to the liver. These clotting factors, there is significant derangement causing coagulopathy. As we know, the portal hypertension, cirrhosis means portal hypertension, means ascites, means varices. As there is portal hypertension, the blood from abdomen, gut, lower limbs, it is uh, bypassed. Instead of going through IVC, it goes through SVC, that is superior vena cava, and that is the reason why there is opening of so many collateral veins causing esophageal varices. So varices is very, very, very common feature of CLD. So this autoimmune hepatitis patient may directly present with bleeding varices as well, because that can be one of the presenting feature. So if this patient present with infection, sepsis, bleeding, then the patient may directly present to the hospital with hypotension. And the other lipid features which the patient may have is SLE-like features, like the patient may have rash, the patient may have malar rash, the patient may have proteinuria, hematuria, patient may have renal failure. Then rheumatoid arthritis, like bilateral symmetrical. The best definition of rheumatoid arthritis is it is a bilateral symmetrical inflammatory polyarthritis involving primarily the small joints, and usually more than 10 small joints are very commonly present in rheumatoid arthritis, and mainly it involves small joints of hands and wrist, and it involves the larger joint, but always after the small joint involvement. So presence of Sjogren-like syndrome, Zika-like features can be there, like dry eyes, dry mouth. So this could be all the clinical features that the patient may present with to the clinic in a patient with autoimmune hepatitis. Now, how do we investigate? As it is hepatitis, we should always start with LFT. Then bilirubin can be slightly raised, but usually it is never more than 7 or 8 or 9 or 10, because primarily it is a disease of hepatitis liver, so there will be deranged uh, SGOT and SGPT, that is ALT and AST. But these are not usually more than 3 times. If there is sepsis, or if there is hypotension, or if there is any other cause, then bilirubin can be much more high and ALT, AST can be much more high. But usually bilirubin is found raised, SGOT, SGPT is found raised. If the patient has coagulopathy, then prothrombin time may be raised, and the patient may have coagulopathy as well. As we have said, the rheumatoid factor may be found high, the ESR, CRP, these things are very commonly found raised. ANA can be positive, so depending on antibody, if we investigate, anti-nuclear antibody can be positive in type 1 autoimmune hepatitis. Anti-LCAM antibody can be positive in type 2 autoimmune hepatitis, and antibody to soluble liver antigen or antibody to liver pancreas antigen can be positive in type 3 autoimmune hepatitis. Uh, as we know, uh, these patients may have cirrhosis, so presence of ascites can be feature. Presence of portal hypertension can be there. There can be portal hypertension and multiple splenic collaterals. There can be ascites. There can be esophageal varices, which we can find in endoscopy. Patients can have spider nevi, spider angioma as a part of cirrhosis. Patient may have reduced beard hairs, reduced pubic hairs, reduced axillary hairs because of the cirrhosis. Patient may have gynecomastia because of the cirrhosis. Patient may have pedal edema, which is pitting, that can be because of cirrhosis. So these are all the features of cirrhosis. The same way, albumin is very commonly found low, which is very commonly associated with pedal edema, which responds very well to diuretics and albumin supplementation. So, as I said, some patients may show marked derangement of SGOT and SGPT, especially if the patient has hypotension, sepsis, or other comorbidities as well. As a part of cirrhosis, the patient may have anemia, thrombocytopenia, leukopenia, or this can also be present even in absence of cirrhosis. So presence of infection like urinary tract infection, pneumonia, brain abscess, meningitis, or abscess anywhere can be found, which need to be taken care of and has to be treated. Now, how do we diagnose? It's very simple. Any patient presenting, especially a female gender patient, whenever presenting with derangement in LFT, especially SGOT, SGPT, and in absence of any structural lesion of liver on sonography or CT scan of the abdomen, in absence of any drugs, any toxin like alcohol or any other drug or any other toxin, and after exclusion of viral markers like hepatitis A, hepatitis B, hepatitis C, hepatitis D, hepatitis E, uh, if a patient is presenting with these features and with presence of this positive ANA or positive anti-LCAM antibody or presence of antibody to soluble liver pancreas antigen, we can label that the patient has autoimmune hepatitis. Uh, the confirmed diagnosis can be made only on liver biopsy, which usually suggests that there may be a piecemeal necrosis or presence of rosette formation highly suggests autoimmune hepatitis. Now, how do we treat it? Treatment is pretty straightforward. Supportive treatment has to be given. For example, if the patient has hypoalbuminemia, albumin has to be given. Diuretics has to be given for edema. Nourishment has to be given for nutrition. Then the treatment of sepsis, treatment of pneumonia, treatment of UTI, this thing has to be given. Calcium, vitamin D, bisphosphonate, these has to be given. For anemia correction, iron has to be given, folic acid has to be given, B12 has to be given. So these things has to be given. If the patient is dehydrated, the patient has to be hydrated. If the patient is presenting with hypoxemia, oxygen has to be given. Patient has to be stabilized. So this falls under supportive treatment. And in definitive treatment, what we need to do is the mainstay of the treatment is steroids. So usually 1 milligram per kilogram per day steroid is started. So most of the patient will be between 60 to 80 kg. So 60 to 80 kg steroid can be started right away, and it is gradually tapered over few weeks to the lowest possible dose. So the patient can be put on steroid, for example, at 60 milligram per day for 6 days. Then it can be tapered to 50 milligram per day for 7 days, and then 40 milligram per day for 7 days. So over a period of time, most of the patients are put on lowest possible dose of steroid, that can be around 5 to 10 milligram of steroid after around 1 to 1.5 months. Now, what are the problems with steroid is hyperglycemia, increased BSL. So that has to be treated with insulin most of the time and physical exercises. Osteoporosis is very commonly seen with steroids, so supplementation of calcium, supplementation of vitamin D, and supplements of bisphosphonate has to be given if it is necessary to tackle the osteoporosis problem. Infection risk is definitely there, so any prior infection has to be adequately treated. Vaccination has to be considered, especially against pneumovax, especially against H1N1 and H3N2. Very commonly, steroid causes this hypertension because steroid causes sodium and water tension. So, if a patient has hypertension or if the patient develops hypertension because of the steroids, it should be properly treated with antihypertensive drugs. The one of the most important steroid-sparing drug is azathioprine, and it has to be started. It can be started on the first day with steroids, or it can be started after a few days after starting steroids. And mostly the azathioprine has to be continued for lifelong with lowest possible dose of steroids, or if the patient is very very well controlled on the steroids, then preferably we can stop the steroids and simply continue azathioprine only at the lowest possible dose for the rest of the life. So if there is no sign of the active disease, then we can stop the steroid maybe after 1 month, 2 month, 3 month, 4 month, and we can simply continue azathioprine at its lowest possible dose. Now, these drugs has to be given at least for 1 to 2 years, and if the patient is very well controlled, and if the dosage of steroids and azathioprine are very well tapered with lowest dose, then we can think of discontinuing azathioprine also and see for relapse. If the patient puts or comes into the relapse, then we definitely have to continue azathioprine at its lowest dose, or if it is needed, then azathioprine plus steroid at their lowest dose. In between, whenever the patient gets into the active hepatitis because of the autoimmune hepatitis, then the dosage of azathioprine or steroids may need to be increased for a short period, maybe for 7 days, 10 days, 15 days, depending on the response to the medicines. And very commonly, routine monitoring of hemogram, LFT, and imaging is necessary. The aim of the treatment is always to taper the steroids to its minimal dose and to continue the azathioprine, usually in between 50 to 100 mg per day. If the patients don't respond to steroid, then cyclosporine or mycophenolate mofetil can be considered. And if the patient is not responding to the treatment, then the ultimate treatment is liver transplant. So this was the long answer question to autoimmune hepatitis, and I'll be coming with more and more long answer questions very soon. And thank you.